So maybe as folks are filtering in, we'll go ahead and find seats and get started. We have an early stop today because there's a meeting here at 9:30. So we've got a bunch of folks online. I'm hoping we're going to have this monitor in the future. It's kind of like we can't see folks, but as we can see, I think these are folks that have joined us on Zoom, and we'll try to engage our colleagues on Zoom. So thank you all for being here. Happy Friday. Happy fall. It's happy homecoming. 50 years of Blazer, nation is pretty awesome. So, so my topic, I gave this talk for the first time last year and would really welcome your feedback in terms of how helpful it is or is not, or how it could be better. But it's my second year to do this, and it really builds off a presentation that Andrea gave earlier on about kind of generating your research question. And the focus of this was, once you have your research question, what do you need to do to actually conduct a project and complete a project and get products? And I emphasize products because sometimes I think there's opportunities for scholarship that is not just the primary outcomes of that project. And sometimes we don't always talk about that and think about those opportunities for scholarship. So I will say this has been, a lot of this is the culmination of 15 plus years. So it's synthesized. It looks like kind of a one-year journey or project I'm going to share with you, but it really is the synthesis of 15 years coming together. So it really is not nearly as clean and neat as it will appear. I'm going to go through the steps and actually kind of interject a presentation that I did my first year on faculty, kind of with my first project at UAB, just to give you a sense of the steps and how it looks for me and how that kind of works. So I did an ORC T32 fellowship at Duke, finished in 2006, came back to UAB in 06. And 1917 clinic, the HIV clinic, in the conference room, there was just this blank whiteboard. And I was like, what am I going to do? And had some really wonderful colleagues, and we sat down together. And the guy, Jeff Samet, up in Boston, had done some pretty cool work and kind of came up with, here's what we wanted to focus on. So that there was a lot of work done on HIV testing and linkage to care. And on the other end, clinical outcomes and adherence to medicines. But in the middle, the idea of adherence to care wasn't really studied. So it was kind of seen more as just kind of process or just kind of clinical stuff, but not necessarily a research entity. So working with an interdisciplinary team of doctors, nurses, social workers, psychologists, epidemiologists, biostats. We had a weekly research meeting, and on the whiteboard kind of drew out this picture, kind of going through after testing, someone has to get linked to care, keep coming into that medical care to receive the antiretroviral medications, to have optimal outcomes. And this is generalizable, I think, to any chronic disease, really, you could think about it. So this is kind of the starting point of the work that we did. And so I'm going to go through kind of step by step. And I think the first step with a project, as fellows, pre-docs, postdocs, whether you're working on your dissertation or working on a number of projects for 2 years, is your research question. And kind of a few weeks ago, this is where I started. I started off with a question of, what is the impact of missed clinic visits on HIV outcomes among adult persons living with HIV? So is that a good question?
It's not very focused.
It's not very focused, yeah. So it's an okay question, but it could be better. It could be more focused. How could it be better?
What is the impact?
Yeah, what is the impact? Maybe defining that a little bit better.
Like, what is outcomes?
What is outcomes, right? Outcomes could be just about, outcomes is pretty darn broad. So absolutely outcomes. And then, also, clinic visits. What kind of clinic visits? Is with who? Is it with the nurse, with the doctor, with the social worker? So, it really is a bit vague in terms of, persons living with HIV have lots of visits. So after going through that session, I think my question got better. So I kind of got rid of the impact and what are the effects? So thinking more about effects or effect sizes of missed primary HIV medical care visits with a prescriber. So much more specific. What am I talking about? Instead of outcomes, all-cause mortality. Very hard clinical outcome, very focused, very specific among adult persons living with HIV, but also who's my population who are newly initiating medical care at this one clinic. I'm going to study it initially at this one clinic. So went from a more broad question that could guide maybe a bigger picture, but for this specific project, kind of refine my question to be more specific to this study, this project, this population. That's what I came up with. So, and anytime you see this font, this is actually the PowerPoint presentation that I did over a decade ago. So it's just going to kind of show you how going through these steps, how it translated to me giving this presentation for this project a while ago. And so anytime you see the green in the heading, that kind of goes back to this presentation that was done. And the question, these are the kind of questions, and that's kind of what it looked like at the time. So the next step, so when you're starting a project, once you have a question and it's a good question and you've vetted it with your mentors and your colleagues and others, is reviewing the literature. So, what is the state of the science pertaining to your question? What is known? What is unknown? Is there consensus, controversy? Are there unique opportunities to contribute to the literature? So chances are when you have a question, it's not in a vacuum. I mean, other folks are thinking about this, have thought about this. So a first step is always going to the literature and trying to figure out, what's out there, what's published, what's known. And I will say, it's only in recent years working with a number of different pre-docs and postdocs and early stage investigators that have taken advantage of the lit search as an opportunity for scholarship. So opportunities, there's a number of different kinds of reviews or literature syntheses that can be done. So the most intensive is a full systematic review, maybe adding a meta-analysis, meta-regression. That's a really intense process. And sometimes folks think that's just more than I can do. There are other literature syntheses ranging from narrative reviews to scoping reviews that are similarly rigorous, follow a process, but sometimes don't come with the same intensity of a systematic review and a nice opportunity for scholarships. I work with someone at Hopkins, just did a scoping review looking at employment among African-American persons living with HIV and was done like in 6 months and wrapped it up and kind of wrote a paper. So the idea that when you're reviewing the literature, if you do it systematically, and there's great resources available at the library here, I'm sure at our partner institutions, librarians at medical libraries are just tremendous resources, very collaborative, very helpful. Kay has come and spoken with us before. So an opportunity to kind of engage with someone who knows this process, knows how to do this, and really to kind of get a piece of scholarship. So if you're reviewing the literature, why not take something, package it, publish it, and that's kind of your first publishable thing even before you've done the project. So put a plug in for that. And again, I mean, this is not something, I did not do this at this stage of my career, but had Rebecca Duran, who is one of our TL1 year out scholars, and she took this on and did this amazing systematic review, is now working on the meta-regression, but did this systematic review, this is the table, there for illustrative purposes, not to read, presented at a conference and is now working on the manuscript, having done this. And so a really nice opportunity when you're doing your kind of work and reviewing the literature to get a product out of it and get some scientific credit for it. So this is kind of in terms of the literature review in the presentation kind of talked about. There's growing interest in expanding adherence to include linkage and retention in care. Previous studies have shown that missed outpatient visits are associated with lower likelihood to receive medications, higher rates of viral failure, the emergence of resistance mutations. However, there really was a paucity of data on missed visits and clinical outcomes, including mortality. So in this presentation, trying to say, I reviewed the literature, I know what's known, here's where there's less known, here's kind of where this is going to fit in and kind of contribute uniquely to the literature. So we'll pause there and say, has anyone ever conducted any sort of a systematic synthesis of the literature? Awesome. So tell me what you've done.
Mine was on a systematic review of correlates of suicidal thoughts and behaviors among transgender people. So
Okay.
not lumped in with like LGBT people as well.
Cool. How was that process of doing the systematic review?
It's pretty intense.
Yeah, it's intense.
It's like identify every source that you'll look at, really define your search criteria. In fact, after I did mine, I realized I didn't include gender dysphoria as a search criteria. And I think there are a lot of reasons you could argue for doing that versus not doing that. But
Sure.
I had to do that after the fact
Sure.
of already searching the literature. So yeah, there's a lot of potential pitfalls.
A lot goes in, yeah, a lot of pitfalls. And did you have help with it? Who helped you? Who helped you do it?
Yes, I had a fellow graduate student in counseling psychology help me with it, and I had a supervisor in the suicide literature and then a supervisor in the LGBT literature, and we all just kind of worked together as a team, but me and the other graduate students.
And anyone with expertise like in systematic reviews or literature syntheses?
No, but I did meet with a librarian before I started.
That's always a good idea. Yeah, no.
Very helpful.
Yeah. Other experiences?
Yeah, I did mine on treating anxiety and depression from bowel disease and psychological approaches. Because the current treatment, standard cognitive behavioral therapies like not as effective in that population for some reason. So we were trying to get more like nitty-gritty and like what components work best, like what components of CBT work best in that population. So we did like a unique methodological approach, or like wasn't quite a meta-analysis, but we broke those treatments down into their individual components. But also, yeah, I experienced a lot of potential pitfalls and didn't really realize the resource that the library would be until, you know, I started coming to CCTS seminars and that sort of thing, which is towards the end of mine. So I sort of did a lot of Googling and found some good, you know, like resources with like Prisma guidelines and that sort of thing to make it more of a rigorous process. But yeah, it's pretty intense.
Yeah, no, so there's resources available, and beyond the library, there's other folks on campus with expertise. I mean, Jazz Singh helps with the Cochrane syntheses, and there's other folks. There's a group out of the Nork that does incredible work. So there's a lot of times there's resources and folks that do this that can be wonderful. And, you know, Rebecca and I sat down with, you know, someone and just kind of got this consultation, and kind of, it was very helpful before jumping in, like, here's what you're jumping in for. Anyone do like a scoping review or a narrative review? I think that's somewhat newer, that approach of, have you done it?
Yeah, well, I've assisted someone in doing it on children with special health care needs in private, covered by private insurance.
Okay.
Discrepancies and all kinds of outcomes, like continuity of care and financial toxicity, things like that.
It was like a scoping review?
It was a scoping review.
Yeah, no, it's kind of neat. It's a different methodology. A lot of times folks are not as familiar with the narrative reviews, scoping reviews, but a good opportunity to think about doing something rigorous with methodology, you know, and get some scholarship. So have they been published?
Ours is under review.
Awesome. Yeah. All right, cool. So you have your question, you've reviewed the literature, conceptual model. So I think for a lot of the work that we do in the health services, outcomes, population health space, and again, full disclosure, I'm a physician trained in health services research. I'm not a behavioralist. Have the expertise. There are many of you in this room that have way more expertise about conceptual models than I do, but just kind of going through the steps. And you know, just thinking about a conceptual model, you know, really a framework that helps to address your question, a visual heuristic that depicts the relationships among your proposed, you know, multi-level factors that might contribute to behaviors or outcomes. So kind of explanatory model. I want to explain what's happening. You know, a grounded framework to inform interventions to modify health behaviors and outcomes. And a roadmap to guide a scope of work for a grant or research program. So I will say for me, and I've learned so much from different colleagues over the years about models, you know, the idea that, you know, you have a model, it might change over time, but the idea of, for me, has been developing a model for an overall research program. Not like this is a model for this one question. I got a very focused question I'm talking about right now, but like the idea of, it's in the broader context of really understanding the environment, individual level, community level, different factors. So, you know, I challenge those that haven't done this to really think more broadly beyond your question about developing a model that recognizes, I'm asking a very focused question as a pre-doc or postdoctoral fellow, but this is in the context of a much bigger picture and a longer term kind of goal for me in my research career. And again, developing a model, an opportunity for scholarship. I mean, I think this is something where I learned this again later on, but you can actually publish, and I'll show you a few examples of where folks have published. So you know, so for me in my process, on my journey, first year faculty, went to Susie Davies, who's in health behavior, and was like, you know, here's my conceptual model. And she's like, that's not a conceptual model. It's a nice little diagram, but that really doesn't speak to. I'm like, oh, but look, it's even better now. We've gotten to the fact that, you know, retention comes out and there's bi-directional relationships. And she's like, yeah, guess what? That still isn't the conceptual model. So it was really helpful and helped me to learn along the way. But this idea was, this is our framework from a clinical perspective and thinking about, you know, going through these different steps. And I think, you know, advancing our thinking, working with Kim Hewlett. So Kim Hewlett was at the time a medical student who worked with us on a scholarly activity, and she actually went on to publish this and the next model I'll show you as part of her work. But I think, you know, we advanced it from a clinical perspective, but then Susie helped us and said, like, here's a conceptual model. So we went with, this is Anderson behavioral model of health services utilization. If you have any interest, this paper that was published in '95 was him giving a speech at a society meeting where he was awarded with like an Emeritus Lifetime Achievement Award. And it's really cool because he goes through from the 60s to the 90s how this model evolved over time. And it wasn't just him, there was Lou Anna Day, many others contributed to this model, but a really neat paper to see even how a conceptual model can evolve over time. But this was kind of what we came up with. So our more clinical example of linkage to care, retention, and re-engagement and art receipt were now our health behavior. So my little simple flow diagram from the whiteboard, from all those wonderful folks working together was here. But then the idea that there's an interplay of individual characteristics and predisposing factors, enabling factors, and perceived need, interacting with the environment. And it can be both the contextual environment where someone lives, as well as the healthcare environment where someone might receive and access care, but the relationship between the individual and their environments influences these health behaviors. And then to the point about outcomes, lots of different outcomes. It could be things like quality of life, things that are biological like CD4 or viral load. It could be clinical events, it could be mortality. So again, Kim did a specific project, but as part of that project, went ahead and published this conceptual model as part of what we were doing in some of our thinking. So an opportunity there. Working more recently with Crystal Chapman-Lambert and Letitia Alopre, they kind of developed a similar model where they actually embedded the information, motivation, behavioral skills model, in terms of the health behaviors within this Anderson model, looking at the environment and population characteristics and looking at PrEP among women, PrEP uptake among women. And again, this paper Crystal published in JNAC, and it was really cool. This was the paper of the year. At their annual meeting, she's going to have like a podium presentation to go over this paper. But the idea that you're developing this conceptual model, you're adapting a model that exists for your purpose, there's opportunities to publish this for scholarship and to get kind of credit for doing that work. So seek out those opportunities. Jesse Merlin, who is here, did a biopsychosocial model looking at chronic pain among persons living with HIV. So different biological factors, psychological factors, social factors, the interplay of those with pain influencing outcomes. Again, Jesse in pain practice many years ago was able to publish this conceptual model, adapting this model to her specific question and population to kind of really bring this to her audience, which might be a different audience that hasn't seen this kind of thinking. So a colleague of mine, Revea Miko, who's presented here in the past about conceptual models, in a paper in JGIM, kind of gave some example conceptual models. There's so many that are out there. And again, so many of you have way more expertise in this than I do, but thought we'd pause and just, if anyone wants to share what models they use or have used or are using for their current projects or thinking about using, please.
I'm using the theory of unpleasant symptoms, but anything that really came from San Francisco, like the symptom management model, I like.
Okay, cool. Anyone else? Zoe?
I've used social cognitive theory as a model in the past, which I really like because it kind of incorporates parts of the health belief model and other individual or interpersonal models of health behavior, but a key component of it is a reciprocal determinism between the health behavior of the individual and their environment. So it's one of those that kind of transcends individual factors and environmental factors.
Very cool. And you bring up a great point, and I will look to colleagues in the room, Fabrice, others that have much more expertise than me, thinking about theory versus conceptual model. Are they different? Are they the same? Does theory inform the model? Again, I'm out of my league, so I'm like, phone a friend, I need help.
I would say theory informs or should inform the model.
Yeah.
So I use stress process theory or a stress process model, and so much of the inner workings of that model focuses on these theories that kind of link stressors to health outcomes. Stressors influencing could be cortisol or something else along those lines. But yeah, theory, I've always been told, should inform your model.
Okay. Thank you. I appreciate that. Yes.
Kind of follow-up question. I've always heard about there is a difference between a theoretical model and a conceptual model, but I've never heard it articulated well, nor can I do that. So,
and nor can I. So
is there even a difference? Like, I don't know.
I would love opinions in the room, folks that are trained in medical sociology, psychology, other disciplines, behavioral. I mean, is there a difference between a theoretical model and a conceptual model? Is this kind of a semantic discussion? Is this
I mean, that's all it is.
Yeah, I think the distinction, at least this idea between theory and a model, I see that where the theory kind of underpins the model, but the model, and again, if anyone disagrees, if I've misspoken or someone doesn't agree, let me know. We're all here to learn together, but I see this model as more of a concrete framework where it's not theoretical, it's concrete. It's things that I can measure. I can measure those contextual factors, those environmental factors, those individual, I can actually measure those things. And I'm not just throwing them up there, I'm throwing them up there in very particular sequences. If there's one arrow going one direction versus bidirectional, it informs how I'm going to not only measure, but evaluate these relationships. I'm saying there's a direct relationship that this works through this, and would go to someone like Emily and say, well, I think this is a mediator on the causal pathway. That's what my model is showing. How would I think about, evaluating this and analyzing this when I'm designing my study?
I think it comes down to, like you said, semantics. It's theory versus concept, theoretical model, concept and bigger picture puts together potentially many theories within it that you were just talking about that could influence a certain outcome. So you can have a different theory within your intervention, and your intervention is your concept. So I look at it too.
So from my behavioral training, what I remember, that theory is a little bit more broad, and it's usually developed based on research in several areas. For example, Brad's theoretical model of change is a theory that developed from smoking cessation first, but then was applied to substance use disorder broadly.
Yeah.
And the conceptual framework, I think it's more application to a certain, problem, how behavior problem or health problem or
Right.
medical problem.
And I'm with you, but again, I think we come from a similar lens as physician clinicians doing this work. But we have a shared understanding. Carlos.
So you can envision this in the future, regardless of what model you use, the state where you're going, and so forth, thinking all the way with the end in mind in terms of a grant application or a paper. Let's say a paper, if you don't have any model whatsoever, you're probably going to be in trouble. If you put too much information of a model in a journal that doesn't really read very well about models, you
Right.
need to translate that for that audience.
Mm-hmm.
In that way, you target whatever paper you're doing to the journal and the audience that you have. And just be mindful that.
Oh yeah, no, it's a great point. I mean, always know your audience, whether you're giving a presentation, whether you're putting in a grant, whether you're putting in a manuscript. I mean, if you submit something to a nursing journal, I work with a lot of folks in nursing, and you don't talk about theory and model, like you're just summarily dismissed. I mean, it's just part of the culture and the expectations among nurse scientists. So I think it's all, knowing, whereas if you go to a very medical journal and you're talking a lot of, psychology, sociology, jargon, it's just like, whoa, how does this apply to me? So I think knowing the audience is key. Emily.
There was a comment that I think people online can't necessarily hear what the attendees are saying, so if you could repeat.
Oh yeah, will do. Thank you. Yes, thank you. Appreciate it. I didn't know if I thought we were having a press conference. I saw the microphones. I was like, I've seen similar pictures with a very powerful woman, but I'm gonna.
There's also a question Riley online asked, I'm curious how you go about developing a good question for this type of research, or how do you tell your research question needs to be this depth, systematic review?
So in terms of developing a good research question, I'm not sure if Riley was able to join. I would refer back. I think it's taped and archived. We had the session on developing a good research question. Whether or not a question, I don't think the question is as amenable to the systematic review as the topic area. I mean, so, in thinking about your topic area, when you do a systematic review, as those that have done it, you have to get specific because you do have to have terms and be specific. But I can't think of any good question that doesn't require a literature search that's amenable to some sort of a literature synthesis if it hasn't been done. And if there's not a literature synthesis that can be done about a question, I would really ponder about the quality of that question. All right, cool, thank you. So a next step, and I will also say I'm doing these as steps. This is by no means sequential. I'm going to kind of list them off at the end, but these are things that you're doing, not in sequence, but they're happening in parallel. So in terms of a data set, are you going to do a secondary analysis of an existing data set? Are you going to do primary data capture? And there are so many data sets that are out there and available. So it could be your mentor's research grant. There's longitudinal cohorts. We're very fortunate at UAB to have access to things like Cardia and Regards that are just a wealth of information. Medicare, Medicaid, national registries like SEER that many have used in this room. National surveys are out there. I mean, it's, that you can use. And UAB health system data. I mean, so we have a lot of data captured in the health system, some elements better than others, but a whole wealth of data that's out there. I will say generically, my advice to folks doing a postdoc is to try to not get spread too thin. And my generic advice is, 2 projects, 1 project using existing data and 1 project with primary data capture. I think there's tremendous value to doing both. I think the value of the existing data, it'll take this full 2 years of a postdoc to go through all these steps and have something submitted and hopefully close to publish when you're done. The primary data capture, typically the return on that investment is not until years later, but the value of going through the process of setting up the study, capturing the data, and doing something if you can, I think are really complementary. So, Emily.
I would just put in a plug for Medicare and Medicaid claims databases being more like primary, and timeline being more like primary data collection than like
Great, thank you.
Secondary analysis of something like regards.
Yeah, so that's very helpful to know. Yeah, even secondary data analyses might have a timeline that are not as amenable to, yeah, so that's a really, thank you for that point. So again, this is going back to the presentation. This is a fancy slide we had, like, over a decade old, just showing the different data elements that we had over time and how our database had expanded. So in terms of data, I wonder if folks want to share is anyone doing a secondary analysis, have a data set? What's the data set you're using?
The National Vital Statistics.
Okay. And where's that housed? Does CDC house that? Or?
National Center for Health Statistics.
Okay. Accessible, can get it, work with it pretty well?
You can only get it at the national level publicly, but it records every live birth in the United States every year.
Wow.
It's over 100 variables on every live birth.
Cool. Yeah. Nice. Others?
Using Health. It's National Study Health.
Where's that house? Who can?
UNC.
Okay, and you have to request access to it, or is it publicly available?
It's publicly available for most of the variables. Some are restricted.
Cool. Anyone else? Anyone using a mentor's database or grant? Yeah.
I'm using my mentor's study, and I have it on Red Hat right now. So.
Okay, and it has the elements that you need for the most part to do your.
Yeah, it's not perfect.
It's never
I'm
perfect.
taking some stuff from multiple instruments to represent the constructs that I want, because there's not like a measure that represents specifically what I want.
No, that's great. I think it'll lead into the idea of selecting data elements next. It's hard because we all want something. Sometimes this is the data set available to us, and rarely does it match where it's like, oh, this is my construct. This is a validated measure. I'm going to use this. So.
And there's some proxy variables that I've had to write pages of rationales for why they are.
Absolutely, right? That's all part of No doubt. No doubt. Anyone else want to share what data sets they're working with? All right, cool. So identifying your study measures and variables. And this is, again, why it's so important to think critically about your conceptual model and think comprehensively. The idea that you really should be selecting your measures that map to your model, ideally. I mean, your model is giving your depiction of what you think is happening, so your measures should kind of reflect that model. As was just discussed, I mean, really important to acknowledge limitations and biases with all measures. There is no perfect measure, like none. So I think recognizing that even when you have the wonderful statistics, here's the Cronbach alpha and all those things, really recognizing that any measure that you use, and oftentimes we are using proxies, and recognizing it's not perfect, but it's trying to approximate truth as best that we can and measure this as best that we can. I was taught this as a fellow, and it still rings true for me today. If you're doing primary data capture, if there's an existing instrument to capture your domain, stigma, resilience, you name it, especially if it's been validated in your population, much better to take something off the shelf and use it than develop a new one. The caveat being, if you want to have a career in psychometrics and instrument and survey development, it's a wonderful career. But if that isn't your goal and your pathway, if you start, you can't just throw together 5 questions and say, here's the instrument. I mean, that's not going to fly in the peer-reviewed literature. So I think you've got to be mindful of, if something exists, much better to grab it off the shelf than trying to de novo, unless, again, you want to. And there's a wonderful career in doing this kind of work, but it's a different pathway than using existing things and answering questions. I've never been able to say everything in my model comes together and I've achieved this incredible study. I mean, it really is this idea that with this broader model, you're getting different pieces in different projects, and over the course of many, many years, trying to put all the pieces together and really understand how it all fits. I will say, again, I'm trying to focus on resources available. So the CCTS BIRD is an incredible resource, both in terms of design, but also your measures and looking at your model and thinking through things. Informatics and Informatics Institute can also be helpful in terms of data management, especially if you're looking at health system data here at UAB. I can't speak to our partners' sites, but Matt Wyatt, can help with using I2B2, extracting data, folks that want to use health system data. Other resources for Medicare, Medicaid, folks like Emily, there's different individuals for these different data sets, and if there's interest, we can try to help connect you with who the right point person is for these existing databases. And so coming back to my model, I got this big model. So for this first project I did, my first year at a fellowship, here's what I had. I had age, race, ethnicity, gender. I captured mental illness and substance use via diagnoses. And diagnoses in a chart by no means capture effectively true, the mental illness and substance use. We had insurance, so that's captured pretty well in most health systems because it's done for billing purposes. And then we could get all-cause mortality. So this is what I had. So for this project, there's a lot of stuff that I really want to measure and that I really think is going to influence the relationship, between missed visits and mortality. I just couldn't capture, and just acknowledging that, and that's kind of okay for a first study, especially if the literature hasn't looked at these things. If there's been 5 studies that look at these things, probably not going to add much, but if there hasn't been, maybe it's enough to have these things to kind of, go forward. So going back to the presentation, kind of acknowledge, hey, mental health, alcohol, substance disorders were from the medical record and not standardized instruments. And we're very fortunate in 1917, we now have patient-reported outcomes. So we do the PHQ-9, the audit C. So now we have validated instruments that we can use to capture these things. But back in the day, we didn't have them. And it was stuck with, did a provider document it? And we've shown since with the PROs, this is very inexact. And there's a lot of misclassification using these diagnoses. So next step, and again, this is by no means sequential. Every time I see Emily, I'm like, this comes in the very beginning, the idea of developing your plan and your analysis plan. So what is your study design? And Emily gave us a great talk about different designs. Is it prospective versus retrospective? Is it cross-sectional, longitudinal, cohort, case control, randomized trial? All those kind of design-related issues. Really defining your eligibility criteria, right? Who is eligible and ineligible? You're going to have to define this in your methods section very well, and it's also going to help in terms of extracting your data, who's included, who's not included, and a rationale. You got to have it can't just be that, I just didn't, and really explaining why you did or didn't. And a detailed analytic plan, and starting with descriptive and unadjusted, as well as adjusted methods, power and sample size considerations, handling of missing data, I think is really, really important in the work that we do. There's a lot of missing data. If you only have data from half of your folks and you analyze it, not explaining how you handle the missing data from the other half, how do you really draw inference from half your population that you sampled? And recognizing and acknowledging limitations. I think humility in science goes a long way. Nothing is perfect, no study, no grant, so recognizing that, we did the best we could with what we had available. We did it as rigorously as we could, but here are some of the limitations. Here are some of the things we weren't able to do. So a plug for the CCTS drop-in clinics, the BIRD. Has anyone used the BIRD clinic? Okay, awesome. So, they are so valuable, so helpful. Emily, do you want to speak a bit to BIRD clinics or what it's like?
I'm one of the people who's available for individual consultations. I don't actually staff the bird clinics, but you can, my colleagues do, and you can come in, sit down, you'll work with one of the biostatisticians or epidemiologists. They can talk to you about the whole range of analytic and design issues that you might face. They might sort of say, oh, maybe you should talk to this person or that person, but I think that they, generally are a fantastic resource available to anybody who shows up. So it's a good thing. Yeah.
And at what point in your research design or study is the BIRD most advantageous?
So I have had a number of conversations with people who are like, I collected this data, what's my study design? I can help at somewhat there, but it's more helpful to think before you start. While you're thinking about what is your study question, that's a good time to think about how are you going to address it if you're doing an analytic study.
I think you're very kind. It's more of like, oh my gosh, I have these data. What can I do with it? Like, it's probably more of how we, yeah. And you kindly say, well, not so much, but maybe we can make some lemonade. So I think the early kind of reaching out early, getting feedback, getting that input. And I will say something else that I've been able to do. There's a number of different statisticians, epidemiologists that I work with, and we've gone together to the bird. So gone together, me as the investigator with someone who's my primary analyst, my collaborator, and kind of said, we just need someone to help us think about this, and David Redden, Dustin Long, others. So gone together to kind of get feedback and been really, really helpful. Even if you're working with a statistician or epidemiologist, or you do your own analyses, going and getting that feedback, another set of eyes, and thinking through, what am I missing? What are my blind spots? Is incredibly helpful.
Yeah, and I would say, within the bird, we'll sometimes ping each other and be like, hey, I got asked this question, what do you think? Because I think having more than one person thinking about an issue is always helpful.
No doubt, no doubt. All right, so back to this presentation that I did, retrospective cohort study of the UAB 1917 HIV/AIDS clinical cohort, and we captured sociodemographic, psychosocial, clinical data. Our study period, being very specific, was January 1st, 2000 to August 1st, 2007. Tried to be very specific with our eligibility criteria. So this was an initial primary care visit at the 1917 clinic between January 1st and December 31st, 2005. So folks established care within this time period. And I will say, even the methods, we had 2 summer students who went back through independently every single chart to determine, did this individual have care before coming, did they transfer into care? Were they truly new to care? Anyone that transferred in was excluded. And Justin and Sarah were amazing, but went back for years and years, spent the summer doing this work as well as this project. Was really important to say, we know our population is, as best we can determine, truly new to HIV care, haven't been in care before, no care at a previous facility. Anyone who died within the first year, since they didn't have that full exposure period, was excluded. So the idea was, we're going to measure folks for a year, determine did someone miss a visit or not, and then start a survival clock. So if someone didn't survive that first year, they couldn't have the full exposure to start survival. So we excluded persons who died within the first year. Our outcomes, so we had 2 different things. We wanted to say, were there factors that were associated with missing a visit, a no-show visit, and then mortality, and we used the National Death Index. And even with the National Death Index, imperfect. There's misclassification. There are folks who are living who are recorded as deceased. There's folks who are deceased recorded. So recognizing that this is a national index, it's a national database, but it's an imperfect database. Analytically, to look at missed visits in the first year, use logistic regression. For mortality, Kaplan-Meier, cost-proportional hazards analyses. And we did sensitivity analyses. Since mortality was an infrequent event, we did propensity scores. We were about overfitting our model with too many variables, so kind of developed a propensity score for missing visits as a sensitivity analysis. This is back, Hui Lin, who's now in Tampa at Moffitt, did this work, was just elegant and really wonderful to work with her. So acknowledge our limitations. It's observational. We cannot attribute causality. And even now I say, we can't attribute causality from this study. It's a single clinic in Birmingham, Alabama. Is this generalizable? At the presentation, being very upfront about what we can and can't say from this project. So step 7, and again, this is by no means wait till you do steps 1 through 6. So regulatory and compliance is like day 1, right? So this is like absolutely day 1, thinking about human subjects considerations. Even with secondary data, there's still things that need to be considered about human subjects. So do I need informed consent, a waiver of consent? What kind of a human subjects protocol? What kind of documentation? So, and there's resources through the CCTS CRISP. And I will say, the IRB at UAB, and I imagine partners, very helpful, very willing to meet, talk through things. So go and call folks, go set up meetings and talk with them. Really helpful to think through about all the issues around human subjects protections, regulatory and compliance considerations. Has anyone worked with, preparing a human subjects protocol, consent document? Yeah, everyone's got some good, yeah. It's a different, it's different than writing for our scientific peers. It's different than writing, a grant proposal or writing a manuscript, but it's such important skills.
The other regulatory compliance I would add is data use agreements, or
absolutely.
For certain data sets, if you're getting them, there's a legal process that you have to go through there as well.
No, thank you. There's MOUs, DUA, there's all kinds of acronyms, more of the acronym soup, for these things when you're talking about data sharing across sites, even within sites. So thank you is a critical part of this too. And then so, step 8, again, not sequential, engage others, elicit feedback. So we are absolutely in an era of team science. Like there's no way about it. The idea of the N of 1, solo, multiple RO1 and funded investigator is really a rarity nowadays. We are in an era of team science, which I think is a lot more fun with interdisciplinary teams working together. We have this in this setting, which is, just so incredible. And just get feedback. Don't get feedback early and often. Don't wait until you've got a finished product. The works in progress, this panel presentations, peer mentorship, you all are such an incredible resource to each other in terms of sharing things as it's being developed iteratively over time. A lot of times professional societies will have different kind of mentoring and feedback programs. So I know our infectious disease society has these programs where you can get matched up with somebody. If you're going to a meeting and it's available, sign up for it. Go meet with someone, show them what you're doing. I showed on the napkin my little drawing and my little conceptual model, and had somebody from a different institution kind of really help me think through things in a way I hadn't thought about it. And it was so invaluable early in my career and still to this day. And regular feedback. Don't wait for the products. For me, at least, when I'm working with someone and they come and they say, here's my multivariable, adjusted models. I'm like, whoa, I want to see your raw data. So you really kind of going through the process step by step and getting feedback on the question, on the bird, on your data. So critical and helpful. So going back, here's the presentation. We had 567 individuals who met our inclusion criteria. 24 or 4% died within the first year, were excluded. Among those who were living after the 1 year of the visit, 60% had missed at least one visit, 40% had none, and we saw the mortality, just the raw data, there was a higher percentage of folks who had missed a visit who died relative to those that did not. In terms of characteristics, the average age was 38 years, 25% were women, roughly half African American, roughly half men who have sex with men, a third uninsured. Based upon the chart diagnosis, and we had kind of coding for depression and anxiety disorders, was roughly half, alcohol use 20%, and so on. So, and again, the 60% missed the visit within the first year, and 2/3 at the time started treatment in the first year. So in terms of what factors were associated with missed visits, what we found was younger age, African American race, ethnicity, and public insurance. So these were the factors when we said, was someone more likely to have a missed visit or not? These were the factors that were significant. You can see the kind of goodness of fit and the C statistic. And then we looked at the missed visit mortality using Cox models. And what we found was both when we had all of the variables in the model and also when we kind of combined all of the independent variables for this propensity score, there was a significant and robust association with a hazard ratio of 2.9 or between 2.5 and 3 for missed visits and subsequent mortality. And again, our message about this, even now when we talk about it, is that early missed visit isn't causing the mortality, but for us as clinicians, this is such an early warning sign and trigger that something is going on in someone's life that predisposes them for adverse health outcomes. And as clinicians, whether it's social work, nurse, pharmacist, doctor, to have such a powerful indicator that's easy to measure, something you can act on, has really been the kind of clinical message. So step 9, publish. Carlos.
Would you mind going back one slide?
I'd be happy to.
You made me think about something else. So your mentor, your team, we have multiple versions of everything. Your data set, your syntax, your papers, your presentation. And if you lose any one of those, it's a nightmare. I had experienced before. So 2 main key points. So one is maintain 22 backups of the most recent sort of data set in a secure location, whatever, and call it final, whatever product. I think that's a key component that your mentor should have access to, not in your thumb drive, not in your pocket. So one of my fellows lost a 1,700 point data set for 5 years because his computer was stolen and there was no backup system at that university.
Yes.
I'm not kidding, that was the case. So backup. And the second component is log everything you do, keep copies of the syntax, do diagrams as to which data set you have merged. Just have a really good research log with your mentor, the stuff that you use. I have a method that
yes.
it works for me. But
no, these are wonderful points. And I think, with more recent, this has only been more recently emphasized in terms of rigor, reproducibility, and transparency. So clearly now with R2T, there's a need for this the way there hasn't been in the past. But beyond that, I think just the good practice. And so I think, Carlos, your points are so well taken. It's many levels, even in terms of how files are named. So I've had the experience where the analyst calls a file something, sends it to the investigator who changed the naming convention that later on went back to the analyst and like, what file are you talking? I mean, so simple things like thinking about how am I going to name files and save files and make sure my team are on the same page so that we are all calling and saving and naming the file the same way. And your other points are incredibly well taken. Andrea.
Yeah, just piggybacking on that, I think that transcends even this just data reproducibility piece. The research log is key. So even when you're choosing your variables, thinking through the measures, documenting your rationale for why you select a certain, because this takes so long. By the time you come back around to writing the paper, you're like, why did you choose that measure? And why did we decide to put the 5 item and not the 10 item? And you know, so there's all these decisions you make along the way. You usually have hopefully a good reason for doing it. Sometimes that can be elude you later on when you actually have to put it down on paper for somebody else. So just keeping track, and for measures, sometimes I'll make a table and just have like, well, this is what we chose. This is the paper it came from. This is how you actually operationalize this when you come to the analysis part. And this is why we chose to do, you know, the 2 items, not the 10 items, or vice versa. So those kinds of logs are incredibly, they'll save you so much time later on.
So I will add that next year. This is, I think, this wonderful feedback. Have others, I mean, that are kind of newer to this developed processes for logging and documenting? Everyone's, because yeah, I say my systems are not like, I don't have what Andrea or Carlos has. Okay. So publish. Perfect is the enemy of good. I've seen so many folks get stuck on that first draft, and it's like, you know, just write. And again, everyone has a different style, but find your time, find your place, like just make it happen, and don't just stare at the white page. I mean, again, there's different styles. I do all my citations at the end. I don't want to be distracted. I know somebody somewhere, you know, so I'm not going to worry about like right now going to EndNote and making, just get it on paper. And again, everyone has a different style, but do it your way. But I feel like so many folks get so stuck with that first draft. If I get a first draft from someone that's a mentee and it's really good, I'm like, you have failed me. You know what I mean? I needed to see this earlier when it was not in this polished form to give you feedback. You've been working on this for months and months and months. So, you know, the advice of just get something on paper. It's not going to be perfect. It shouldn't be perfect. If you need to iterate it, sometimes good. And if you don't want to give it to your mentor because you want to wait, give it to a peer, give it to someone, but you've got to get something on paper. It's got to get, you know, written and get done. And I mean, I will say for myself, I mean, I didn't do this. I'm speaking out of not success, but I mean, I've got plenty of projects. I spent hours and hours and hours as a T32 fellow that never got done, you know, and I learned from that. And I'm saying, you know, please do as I say, not as I do.
Kelly Kessick, she gave advice here at one of the panels that something that got her speed up and her productivity was starting with the methods section instead of laying out the intro, because you're often sitting there pondering how you're going to make this amazing case about why such and such needs to happen, and that takes so much energy and thought to build this intro section and discussion section. But if you lay your methods and results out, it just starts happening a lot quicker because you know what you did in your methods, you know how you wrote it, and then your results come right after, and all of a sudden you're like, oh, this is, you got 2/3 of the paper written in a matter of a week. And so like starting that has increased my productivity and others as well that I know that have done it that way.
I actually did the same thing recently. I had to start with the methods just because I could not.
You're stuck. You're looking at that white page being like, I mean, I got to make the big pitch.
It's really odd. It makes so much more sense.
So I got Andrea and then Yulia.
2 things that can be helpful. One is, and this tends to happen when you use a large data set. It's not yours because they'll require it of you, but as a general rule, it's probably a helpful tip just for any kind of paper, which is paper proposals are your friend. Because when you have to develop the research question and write half of an introduction just to get accepted, to be able to use the data set, then that becomes the beginning of your manuscript. So that is a really, really good opportunity to do all this sort of synthesizing of literature and really honing your question, because you can then use that when you do your manuscript. The other thing is, something that worked for me early, especially early on, was just having an accountability partner, and that was a peer. And I had another person who was in Peds, and we would go and we would write together. And number one, we would share stuff, and we had similar enough. I don't think we have to, but we happen to have similar enough interests that we could actually serve as co-authors on each other's papers. So that was like a double thing, because then you're getting your own paper out and you're getting a co-authored paper. So having somebody, maybe if it works for you, to try to just give each other deadlines and hold each other accountable, can be really helpful when you're just trying to push stuff out.
So just I got it for the folks online. I don't think these microphones are on. So the really good comments were, starting with the methods and the results, if you have a blank page, because that's easier to kind of describe what you did than the introduction and those things. And then the idea of writing partners, writing friends, sometimes could be both, co-authors, but having that accountability being very helpful. So is that, okay. Yuli.
I just sort of wanted to say the same thing. When you work with the secondary data analysis and the exercise, like for example, Cardi and Regards, so they have wonderful process of preparing a proposal, going to the executive committee and discussing that. Especially in Cardi, you have to build at home. They'll ask you questions, as opposed to Regards, just send the proposal and they discuss it themselves. And usually, it will probably take at least probably a 2/3 of my paper when we prepare it before I even do analysis. And that was very helpful for my dissertation when I did the cardiac data, actually, because I also discussed that analysis plan with the cardiac investigators, and then we might meet it.
Yeah, so thank you for I missed that for the folks online, the idea of a paper proposal, and there's different mechanisms. And so sometimes it's required by these big data sets, but even if not required, good practice. I will say for us, for our research group, we would have research meetings and then someone would come with an idea and like, what's known about it? I don't know. So we developed the idea of having a concept paper. It was very simple. What is your question? What are your variables? Brief literature review, at least 5 citations. So we have to have some context of what is known, so, and then what, and we use that then to come to our research meetings, and our meetings got so much better because it was now we all have in front of us a proposal and a paper. So I think even if not required by a big data set like a Cardia or Regards, good practice to do the exercise. I'm sure there's many examples we could find if someone wants an example, but really kind of forcing yourself to think through these steps in a very simple paper proposal. Emily, do you have another comment?
I was just gonna sort of echo that while you're waiting, because you'll wait a lot for IRB approvals and whatever else, you can actually write your methods, your introduction, and parts of your results. And you are gonna have to go back and edit that sort of based on what you find, but you'll have something solid there, sort of building on your paper proposal. So I have a student now who's, we're waiting on the IRB, and she's working out like all the different iterations of which measure she's going to use, which variable she's going to use.
So it really helps to guide some of the process while you have these lag time and help with getting some of these things done. No, absolutely. So and Mike Zag taught me this. When he looks at someone's CV, he looks at the abstract to manuscript ratio. That is his judge of do folks finish. So the idea of abstracts feel good, and it's wonderful going to the meeting, getting that feedback, getting that rush of being there and presenting. But at the end of the day, the peer review manuscript, that's the academic currency. I mean, in terms of what really kind of counts and gets the most credit. So really important. I will say we've gotten into the habit of the goal is a good draft of the manuscript sent to co-authors when getting on the plane to go present the abstract is kind of a goal. It doesn't always happen, but like that being the goal, hopefully you send it out, it's getting reviewed by your co-authors, you go to the meeting, you're getting other feedback from this broad group of folks at your poster presentation, and then when you come back, you're getting your feedback and hopefully can really, while it's fresh in your head, finalize it, and within a few months of that presentation, have it submitted to your target journal. Another thing I think is allowing your research findings to guide your future questions. So you start with this one project and don't be so laser focused that you don't make some observations that help you say, you know what, I want to kind of go in my next project and study this and work on this and look at this. So here it is. I mean, over 10 years ago, this was my presentation at the 3rd HIV Adherence Conference, kind of what I shared. And then we published the paper. And again, this is my first project as a faculty. And again, building on things that I didn't do at your stage. I mean, for those of you that are with T32 postdoc, I did a number of projects like this. One got done, which was great, but I got a bunch of them still sitting on my hard drive in my archive Duke folder that have got, stuff that didn't get finished. So I think when you're going through all this work and all this effort, kind of finishing it is such an important piece of advice. It's much easier said than done. But we'll say after doing that project, the idea that there were differences in missed visits among African Americans really stuck with us in terms of focusing on health equity and kind of differential outcomes. So the next study that we did, and there's Susie Davies, you can see some of the folks I've mentioned over the years that were so instrumental, Jerome Allison, Hui Yi, Lynn, who was amazing, did a very simple 3-variable kind of Barron and Kinney mediation analysis. So looking at, does African American race and with viral failure, is it mediated by appointment non-adherence when adjusting for these confounders? And in this analysis, we found there was attenuation of the effect size, kind of use this methodology that Jerome Allison had discovered to say, here's roughly the proportion of effect that is explained by missed visits or appointment adherence in mediating the relationship between African American race and viral failure. So, and for us, again, doesn't unpack why is one group versus another more likely to miss visits. You go back to your model, it probably is things like stigma, discrimination, structural racism. So there's so many factors that might contribute to it. But by establishing this is a relationship, this now becomes a target to say, if we can improve upon this mediator, might we then start to address and attenuate and overcome disparities that are observed in clinical outcomes and mortality? Ann Zinsky followed up, this was with a CDC study with 10,000 individuals, and similarly found, there was more missed visits among Black, African American, than white patients. But when you stratified by number of missed visits and viral suppression or viral control, it was almost superimposable. So the idea of, sure, one group is having more missed visits than another, don't necessarily haven't, dug deep at this point into why, but that when you superimpose these things, really there's no difference in viral suppression, when you control for this kind of mediating variable. So we were able to, work then on an intervention to improve retention in care. And this is building upon this one simple question that started my first year on faculty. And this is not planned, this is just serendipity, this is just luck. But did this large trial with these 6 different sites, looking overall at these 1,800 persons, and this intervention, which was enhanced personal contact, improved retention in care by 2 different measures. So 10% improvement by this visit constancy, 5% by visit adherence. At the time, there were no randomized trials that improved retention in care, so it was the first trial to do that. But importantly, there were subgroup effects. So among African American patients, there was a significant improvement in retention in care that wasn't necessarily seen in other groups. So while not necessarily a tailored, targeted, more of a large kind of pragmatic clinic-wide intervention, did seem to have differential effects on a group disproportionately having worse outcomes. And so the next step, was to now, and this is working with Emily and Myra's now a doctoral student, so she finished her, led this project with Jeremiah. So we're now taking that intervention that worked and actually doing more of an implementation science project with 7 different clinics in Alabama, kind of saying, can we launch this intervention and improve both retention and care, but also help to address health disparities that are pervasive and so well observed. This is just the proof. So this was just kind of accepted. It's really exciting. Myra and Jeremiah, who's the coordinator, led this effort. Again, with Emily's a wonderful team. But this was based upon working with these 9 different clinics in Alabama, looking at their no-show rate over time, them saying, gosh, this is a quality group that meets quarterly, that between 15 and 35% is the clinic-wide no-show rate, and kind of, pretty stable over time. And these clinics meeting for quality improvements, saying like, what are we going to do about it? And us saying, well, here's kind of some of the things that have worked. Here's a trial that we were part of, and it seemed to have effects. So this data for care, we do this risk stratification and then use that intervention that was proven effective to individuals. So just to walk you through, and this was amazing, this quality group has collected aggregate data for a long time with data use agreements and MOUs and all the regulatory and compliance. We're now able to get client-level, de-identified client-level data from 8,000 persons in care across these different clinics. And then we just stratify based upon the previous 12 months, how many times did someone miss a visit? So simple, right? But about half of folks didn't miss any visits. We know from other work, their chance of missing their next appointment is less than 10%. Among folks who missed 1 or 2, about a third of the sample, their chance of missing the next visit, 20%. 3 or more is a small 15%, but their chance of missing goes up to over 30%. So the idea of even before someone doesn't attend the visit, we know, their likelihood of missing, and we could intervene with this intervention and try to promote retention and care. And then this is just kind of the schema for what we do with that intervention. But all this, again, the details aren't as important as to show, starting with a pretty simple, not very good question that then became a better question, 15 years later, we're now kind of having learned from that work, doing things that are moving from this observational kind of descriptive study towards really trying to intervene and do something and have impact. And again, did not happen overnight. Certainly didn't happen. This is, stuff I did not as a fellow, but, as an early faculty member. So started here, right, with this little whiteboard, came to here, now we're here, a lot of folks along the way. And so just to kind of putting it all together, I think, these are the 9 steps talked about, at least these 3. I didn't talk about the BIRD plan, but we've worked with folks where actually your analysis plan or your study design can become publishable. If you're doing something novel or different, even if it's applying a novel method to your population, we've published papers about different study designs or analytic plans. So lots of opportunity for scholarship. And I think for me, what's most enjoyable from smaller teams to bigger teams is just the team science and getting to work with so many amazing people, not just research people, but frontline folks. So I didn't really talk about this much, but most of the good research questions that we've asked over the years have come from non-research people. It's been the peer mentor, the social worker, the nurse, someone who is interacting with folks in a clinical setting or community or public health setting who makes an observation and says, I noticed this. And then that kind of becomes oftentimes our best questions to kind of go study and to go and pursue. So I think we've got maybe 10 minutes for comments or questions if folks have some. And thank you all for being here. And again, would love your feedback. This is only my 2nd time doing this talk. So if there's ways to make it more effective, better, add things, take things out, would be very welcome to hear your thoughts. All right, comments, questions? Does this resonate?
And I think it was cool that you did that initial project. That was your T32?
No, so that was my first. So that was my first project as a faculty member after my T32. Yeah, I could try to dig out my T32 project.
Yeah, so that's what I was kind of curious. Is like, since there's so many postdocs in here, what is a realistic time frame for some kind of like applying this to that 2-year, 3-year time frame?
Yeah, so my T32 project that I did for my master's, I started year 1 of a 2-year fellowship, and it was accepted for publication, I think, my first week at UAB. So it took me, the full 2 years. To go from start to acceptance. It's just the nature of, I think, research, right? It's the timeline.
I think that's why when you think about your project, and I think Mike said this, but just to re-emphasize it, having a couple of different things cooking that are sort of at different stages. A systematic review is having done a few that they're painful, but they are in your control and they inform what you're going to do. So that's something you can publish that's largely within your control. Depending on the secondary data analysis, that might or might not be in your control. If you're relying on other people to do your analysis, that just can take a long time, especially if it's part of something that's a big project where you're sort of in line for analyses amongst others. So making sure that you kind of have, and then the primary data collection, again, I had the same experience. I think my paper from something I actually generated came out my first year of faculty after I finished fellowship. So I think having these different things at different stages, so some are more quick to publish, some you're gaining a different kind of experience, ultimately you'll publish, but that's why you kind of want to have 2 to 3, not starting 2 to 10, not 5 to 6, but 2 to 3 different projects at different stages so that you can kind of have an eye towards publishing and recognizing that all these things kind of take time.
Yeah, and I'll say, and for me, I will say my fellow project was about late diagnosis. So it was a social worker at the Ivy Clinic at Duke that said, wow, a lot of folks are just coming into care late with very low CD4 counts. So it was a really simple, went to the literature, it wasn't that much out there, just describing late diagnosis, who are there certain groups that are more likely to present late to care? And then as I was finishing up my fellowship, the same social worker talked about, man, and a lot of folks are missing visits. And I got to UAB with that simple model of diagnosis and kind of linkage. And Laura Secor, who's a nurse practitioner, made the same comment. She said, a lot of our patients are just missing their visits and they're no showing for their visits. So I said, Gordon, who's this amazing social worker, and Laura, who's this amazing nurse, if they're both seeing this phenomenon, there's probably something there. So I didn't come in thinking I want to study this specific thing, but listening to 2 folks at 2 different places on the front lines, building on some of the previous work I did in my T32 was kind of my path. And serendipity, I wasn't planned. None of this has been really planned. You just go with it.
Another question on mine is, what is the approach of conceiving a research question that is ignited by RFA? like an R21 or an R01?
Of developing an, this is purely opinion. And so my, we talk about this a lot in here. I think there's some amount of opportunism that you have to be successful in academic medicine. I am a strong believer of you've got to follow your passion in what you're studying and what you're doing. So, my approach, and again, there's different opinions and different approaches, is unless something is aligned with what you're doing, I think, responding to an RFA and developing a question around that, if it isn't aligned with your why and who you are and what you're doing, is not something that I advocate for. Acknowledging it's a challenging climate, there's different approaches, but my approach is, figuring out who you are, what you're doing, why you're doing it, and trying to stay true to that, but recognizing that there's variability. But Zoe?
Just real quick, any practical tips for selecting a secondary data set? Especially when you're considering these large national data sets, if there's specific factors beyond accessibility and timeline that can help guide you in choosing one versus another?
I think the best thing to do is to talk to as many people as possible. So starting off more broadly with a conversation about, here's my general interest, what data sets are available. Once I think you've settled in on what you want to do, I just think talking with someone who's used that data set, that could tell you, here were challenges, here were good things, here were bad things. So I guess my general guidance would be going to this idea of number 8, engage, others and elicit feedback. So I think as best as you can, because some of these things are so specific to a disease area that you need content expertise. Some of them are broader. Here's a national database that has all live childbirths. One, I didn't even know that existed, so then to kind of talk about, is that relevant, So I think part of it is, and it might not be someone in your disease, it might be your discipline or your disease, but then it might be, here's someone else who we've met at Friday Fellows who's done, found this incredible database. I think the more just kind of talking and getting a sense for, someone that's used it and those things, if that answers your question.
Yes. In kind of stumbling around through some of those national data sets, they have restricted variables, but then sometimes you're restricted in your use because you have to send your code to wherever they house the data. And it's this back and forth at the time. So it really adds a lot of time on, and you don't quite have as much ownership. So that's the most frustrating to consider. Yeah.
Cool. All right, well, great. Thank y'all. Have a great weekend. Happy homecoming. Go Blazers.
And